we talk about hyperthyroidism, hypothyroidism. In order to understand these things, we got to talk about kind of how the thyroid works. I'm hoping that you can see this. I see a glare on this whiteboard here, but I'm hoping that you can see this. But I drew the thyroid gland here. So this is the thyroid gland. It's right here, right in your throat, side of the trachea. And down there they say it's butterfly shaped. So anyway, it's right here. This is the trachea, and this is the thyroid gland around it. Now over here I drew, this is supposed to be the hypothalamus and the pituitary gland, which is right underneath the hypothalamus. So over here I've got the hypothalamus and the pituitary gland. The hypothalamus releases thyroid releasing hormone, and what that does is it comes down and tells the pituitary gland to release thyroid stimulating hormone. I don't know if you can see that, but it says TSH inside this pituitary gland. TSH. So the pituitary releases TSH, and it does this in response to low thyroid hormones. So it comes down here and it lands on a receptor, the thyroid stimulating hormone receptor, and when that receives it, it stimulates the follicles here to act. And they have what they call an NIS pump. That's N stands for sodium, I stands for iodine, and S is symptomer. It's a symptomer pump. That means it's a pump. It's pumping one direction. So what it does is the NIS pump pumps sodium and iodine into the follicle. Sodium is positively charged, iodine is negatively charged. It isn't going to pump just a negative charge in there. It doesn't really want the sodium in there, it wants the iodine in there. The sodium comes along with it to stop from creating a charge on the inside there. Like I've said many times, when you put something negative in, you got to put it in with something positive. And that's okay because the sodium goes in there, but that's going to be balanced out because there are also sodium-potassium pumps that are going to be pumping that sodium back out and pumping potassium in. And so the main reason that I'm telling you this is so that you understand that iodine has to get into these follicles in order to make the T3, T4 hormones, which are the thyroid hormones. So then you get the follicles here. Once they get the iodine in there, they will go ahead, and then there's other things too, but I'm bringing up iodine because it's one of our problems that we'll be talking about later. So these follicles will produce T4 and T3. 90% of the hormone put out is T4, 10% is T3. T3 is a lot more active, T4 is less active. The level of T3 is what's going to give us the response that we're trying to get from the thyroid hormones. And so what do the thyroid hormones do? They will they increase the cellular metabolism, right? They increase the metabolic rate in the cells. And this will do some things. It will increase our body heat, right? It's going to end up increasing our heart rate. It's going to increase our respiratory rate. It's very necessary for the normal development of the nervous system and growth to occur. So those hormones are important. When they were checking on the thyroid, the TSH, free T4 are the labs that are usually drawn, the only ones that we're going to really talk about here. Okay, so if you have an elevated thyroid stimulating hormone and a decreased T4, that means that you have primary hypothyroidism, right? You have decreased thyroid activity. So what that's saying is your thyroid, for some reason, is not making the T4. So if the thyroid is not making the T4, there's not enough T4, so the pituitary gland keeps making thyroid stimulating hormone. It keeps trying to get the thyroid to react, so it's releasing more and more and more, so you end up with a high thyroid stimulating hormone and a low T4. Primary hypothyroidism. Hypothyroidism. Okay, so now let's look at this differently. Now we got a decreased TSH and a decreased T4, right? So now this is different than the other one. The other one was primary hypothyroidism. This one is secondary hypothyroidism. thyroid could do the job fine, but it has to be told to do it. It has to be told to release T4. It's not being told. So the problem is in the pituitary gland is not releasing thyroid stimulating hormone. So the problem's in the pituitary gland. So this is secondary hypothyroidism, right? No TSH, or not enough TSH to tell the thyroid what to do. Okay, so now let's look at another one here. You have low TSH and high T4. That means that the thyroid gland is making a lot of thyroid hormone, because your high thyroid hormone is right here, a high T4. And that will, by negative feedback, tell the pituitary gland, we got enough T4, you don't need to make any more. We got enough thyroid hormone, you don't need to make any more, so don't release any more TSH. So you get a low TSH and a high T4, and that there is primary hyperthyroidism. So this here just means that the thyroid is overactive. We'll talk about some reasons why that could be. I said that we order TSH and T4 most of the time. Sometimes if they have the symptoms of hypothyroidism, yet their TSH and T4 are normal, it could be a liver problem. What happens is, if you remember right when I was talking in the beginning, I was saying that we make T4 and T3, make 90% of what we put out as T4, and just a little bit of T3, 10% is the T3. But I said T3 is the one that does all the work. Where do we get most of our T3? Only putting 10% out. The liver makes it. The liver takes one of, because this is what it is. Your T4 means that there's 4 iodines on it. Your T3 means there's 3 iodines on it. The liver does, it comes, it says we need more, we need to increase our metabolism. So one of the things the liver does is it changes T4 into T3, right? So it takes one of those iodines off, and that's a process that occurs in the liver. So if the liver is not functioning, the liver might not be converting your T4 to T3, and T3 is what does the work. So if we don't get enough T3, because the liver is failing to do that converting, then we'll have the symptoms of hypothyroidism, even though our T4 is normal and our TSH is normal. Then they'll order a T3, and then they'll see that the T3 is low, so then they know the liver is not converting it. Okay, so let's talk about some of the symptoms of hyperthyroidism and hypothyroidism. I'll do hyperthyroidism first. Okay, in hyperthyroidism, thinning hair, a lot of times it's even patchy thinning hair, and enlarged thyroid gland. You can expect an increase in blood pressure, tachycardia, a positive inotropic effect, hyperreflexia, and that kind of is getting away from our T3, T4, if you remember right. Calcitonin, which is released from the thyroid, turns down the calcium. Remember that when we talked about calcium? So less calcium, you get this hyperreflexia. So the hyperactive thyroid may be releasing more calcitonin than we need, so we're driving that calcium lower than what we should be. And also the fact that you're increasing all of this activity. So those two things together can cause hyperreflexia. So we got an increased peristalsis and diarrhea, frequent stools. And along with that goes abdominal cramping. We get warm, flushed skin, right? Because what's happening is we're increasing our temperature. Hyperthyroidism increases your core temperature. You increase that, your body wants to get rid of that heat, so it vasodilates in the superficial blood vessels, and so you're going to be flushed and you're going to feel warm when you touch the skin. Also, they're going to be sweating because of that increased temperature. Yeah, you really won't like the heat. Heat intolerance is a big one. You won't be able to take the heat. And you'll have your book called it Vitiligo, Vitiligo. That's in, I saw that in Lewis, 10th edition, a med surg book. And what that is it's hypopigmented patches in the skin. You have an increased respiratory rate, and you very well might have a dyspnea. You have an increased appetite, right? You need more glucose, you need more oxygen, right? For this increased metabolism. So you have an increased appetite, so you eat like crazy, but you're still losing weight. So weight loss is a real big one. That's a huge determinant. They're eating more, yet they're losing weight. Now let's talk about hypothyroidism. It's kind of the opposite thing here. I talked about thinning hair. With hair, your hair gets brittle. Your hair and your nails get brittle, right? You get periorbital edema, so around the eyes. Constipation, decreased peristalsis. Cold intolerance. Remember before we said heat intolerance. Well, now we're on the opposite side of this. We're not creating enough heat, so you just can't take the cold. You get bradycardia, so your heart rate is slowed down. You'll get a decreased appetite and weight gain. The hyperthyroid guy, the lucky sucker, right, he had an increased appetite, ate like crazy and lost weight. Well, this poor person here is decreasing appetite, not eating much, and still gaining weight, right, because their metabolism has just slowed down so much. And dry skin, they call it myxedema. That's the periorbital edema that I talked about, myxedema. And the face gets kind of puffy, the skin gets kind of thick, and pallor. Right before we talked about that they had the flushing. Well, now it's the opposite. They're not creating enough heat in the core, so the system is trying to shunt that blood into the core, so it vasoconstricts all of our superficial vessels and shunts the blood inwards, trying to save that heat and heat up the core. And now I'm going to talk about a couple of the things that cause this. A real common one is Graves' disease. Graves' disease is kind of interesting because it's an autoimmune disease. Now when we think of an autoimmune disease, we think, okay, this is the immune system has decided something's a bad guy, even when it's not. It's self, but it's going to attack it anyway. And the immune system is going to attack this and destroy it. But that's not the story here. It's not the whole story anyway. What happens is there's an antibody created by some kind of infection, right? They usually come on after somebody has created an antibody that looks so much like TSH, thyroid stimulating hormone. This antibody looks so much like TSH that it will bind to the TSH receptor and fit perfectly. Therefore, it will stimulate the TSH receptor. So what that's doing is it's telling the thyroid, make more T4, T3. So it does. It just keeps making it because it's got all these antibodies coming in there and binding to the receptors, telling it, make more T4, T3. So you got all this T4, T3 being made. So your lab is going to show that elevation in T4, right? Because you're going to see that you're making all of this T4. And unfortunately, it does another thing. It attacks it, right? It does cause the inflammation, and it's hard on that. So even though it's stimulating the hormone, it's still not a friendly thing. It's still an antibody that's calling friends in there to do a job of fighting against this thing. So it's stimulating it and fighting it at the same time. So you get inflammation there. So you might get the goiter, right? The enlarged thyroid. And you're going to have the symptoms of hyperthyroidism. But as it kills off more and more of these TSH receptors, you can progress into having hypothyroidism. It started out hyperthyroidism because you're stimulating all of those TSH receptors in the thyroid, and then it's just stimulating and destroying them as it goes. So as it progresses, you end up with not enough TSH receptors left to make your thyroid hormone. So you'll see people with this. This is a common thing. And they'll say, yeah, well, I was hyperthyroid. I did have it. Now I'm hypothyroid. And you have to watch this because then once they get hypothyroid, they're going to need that synthetic hormone, right? They're going to need the synthetic, the synthroid, the synthetic thyroid hormone. Okay, now another one that I want to talk about. I just talked about Graves with hyperthyroidism. Now let's talk about Hashimoto's. Hashimoto's is also an autoimmune thing, but it doesn't fit into that TSH receptor, but it does incorrectly recognize that receptor as foreign, so it attacks it. So these guys are going to get hypothyroidism. They're never going to get the stimulation in the hyperthyroidism, but they're going to end up with hypothyroidism. So they will have the decrease in the T3, T4, and an increase in TSH. Because with the increase in TSH, because there's not enough thyroid hormone, so the TSH is going to go up. So it's just a case of primary hypothyroidism. Another one to talk about here is just the endemic goiter. Endemic because different areas of the world you'll have this, where they will develop goiters from an overworked thyroid trying to do the job that it can't do. And the reason is because they're in a part of the world where they don't have enough iodine in their soil. So the things that they eat don't have the iodine in it. And when you need the iodine, right? Your T3 means T3 means that there's 3 iodines, and your T4 means there's 4 iodines. That's how important iodine is, right? You need it. And that's why in the beginning I made sure that I mentioned that iodine had to get into the follicle in order to make it. Not the only thing that has to get in there, but I mentioned that because that's important in the disease process, that you know that. Used to be a problem in the United States. I guess in New York, northern New York State, northwestern, I think, which, usually places close to ocean, they have iodine. But anyway, there they had a real big problem with this, and of course the country was young and we had a lot of people there, so they ended up iodizing salt, right? They put iodine in salt. In fact, the FDA made a standard that salt has to be iodized. Not a real big thing right now because we don't get our food from just local anymore. We get it from all over the world, and most places in the world have enough iodine in their soil, but there are places, several places that don't. Like I said, the United States was one of them. We took care of that problem. There's still parts of the world, though, that have these endemic goiters, and they're not able to make T4, T3 just because they don't get the iodine. Okay, when I was talking about Graves' disease, I forgot to mention something. And it's something that everybody thinks about. Let's write it up here. Exophthalmos. So, and that's your eyes poking out. And the reason that happens, it's not directly from the T3, T4. It's not really even to do with that. It is to do with the antibody, the one that stimulates the TSH. Right back when we were talking about Graves, I was talking about that there's the antibody stimulates and destroys the TSH receptors in the thyroid gland, right? Well, that same antibody tends to attack the periorbital tissues, and the fats, all the fats that protect the eye around the back of the eye, get inflamed and enlarged, and they push the eyes out.